Good morning, everybody, and I wish to thank very much the Pontifical Academy, Surellen first, but also Fabio Ferrucci and all of you for listening. A brief sharing of my experience. I'm a doctor, I have no conflict of interest, and I am coming from Italy, from Milano, and I work as a neurologist, but I've been working on disability for the last 30 years. And I would like to start from what I would call the foundation. And let me go very, very, very far. I go to the Genesis. And there is this part of the Genesis in which you have Jacob. While he's going to cross the Jordan, he meets a man and he starts to fight so much and so much. And then during this terrible fight that he will lose at the end, in a sense, he was able to understand that he was in fact winning. And he was winning what? He was winning an angel. And this angel, while he was going to collapse because he was beaten by Jacob, at the very end of this fighting, with a sword, cut his sciaticus nerve, the nerve sciaticus. And what is the message of this foundation? Jacob won the angel, but then he was stepping all his life. And this is called the anthropology of the despite. Despite he was blessed and he was stepping all his life because of this blessure at the sciaticus nerve, despite this, he was able to win an angel. Because this is what we are. We are stepping all our life, but we are human beings able to beat angels. And this is the message. This is the foundation. We are all stepping because we all have somebody that is giving us a sword in our ankle or in our sciaticus. But we are human beings able to beat angels. And this message from the foundation is in contrast with the progresses of biomedicine, I would say, that have been telling us all the past years that we are like a broken car. When you have a disease, you can repair it. And the past century was, in fact, all based on this biomedical concept that you can really repair everything. And that's, of course, the progresses of surgery, the progresses of antibiotics, as well as all the fights against diseases that we have been able to beat. However, we are in new scenarios. We are in a scenario in which biomedicine alone is not enough. We are meeting new diseases, and as neuroscientists, I can tell you that we are meeting diseases in which to say where is the disease is almost impossible to say. And it's also impossible to say what to cut or to add. If you have Alzheimer's, if you have any other neurodegenerative disease, what do you cut? So the biomedical model is not enough anymore, as well as it is not enough in the new epidemiological scenarios in which we are seeing that aging of population together with the increase of non-communicable diseases that are now 50% of the affecting diseases of the population, and that it depends also where you put the threshold. If I put the threshold that perfect view is my threshold, I would say that half of this room has a problem and a chronic disease in terms of your low vision that is altered. And also the age quake. I mean, as a doctor, I will say that's one of the best success of our science, that we are able to make people to age. We should be all jumping on our chairs because people age. Unfortunately, and aging of population is going everywhere. It's going, and this is, you see from this perspective from UN, that in 2050, the darkest part of the world will have a majority of 60 plus people in their inhabitants. We should be jumping for that. We've been able to move all the people to become old. However, we all know, and this is from UN, and you see the all dots represent men and women from different countries. There is a point in which your body ages, and you age, and your function decline. Whatever is the age you're going to live, it says that the 15 years before the expected death, you're going to age, and your body is going to age, whatever is your life expectancy. So we are declining. That is something that we don't like. But at the end, if you look at all these scenarios, we're talking about different things, and it depends on which box you belong. You can speak about people with disability, people with chronic diseases, people with non-communicable disorders, old people, aging people, but we never really speak about the functioning of these categories that are, in a sense, put in different boxes according to where the money is, where the country is working, and everything. That's our foundation, but then we also have some motivation to work in the area of disability, which I think are very strong. Certainly, one of them is the UN Convention. I really do believe that it was a necessary pair of glasses. We didn't need another Convention of the Rights. Wasn't the Convention of the Rights of Human Beings of 1948 enough? Why do we need to do, are people with disability different from human beings for which the rights have been declared in 1948? Why do they need a separate convention? And the point is the rights are the same, but the glasses through which these rights are restated in 2006 were allowing us to read these rights with different glasses. So the rights are the same of 1948. In general and in principle, we are not needing another convention, but it was essential to have this convention, to raise up people that were completely hidden in society. The countries are there requested to identify barriers. Well, I like this wording because it comes back again in my presentation. But then what it is, the UN Convention, it's a frame, it's a political frame. Who, between the politicians that you know, especially 2-3 months before election, will ever deny the right to work to any citizen? But people don't need the right to work, they need a job. And the difference from the right to work and the job, it's enormous. You don't ask the right to work, you want a job. And that's the difference of having ratified the convention. You know who is the first country who ratified the convention? It was China. I always like, because they had the fixed number of disabled. You know, I was working in WHO for many years, and China always had 2% of people with disability. And then they said, well, 2% is too low, and this happened 15 years ago. They said, well, 2% is too low. So they decided, okay, we put 3%. And then, of course, the global burden of disability in the world increased because there are billions. So, of course, the total number of disabled increased. But China was the first country who ratified the convention, which means that ratifying a convention doesn't mean that you apply what it is written inside. And I think this is also a political issue of almost 193 countries have been ratifying the convention. But if you go into the details of which country is operationalizing this convention, that is much different. And so we come into the disability issue, and that's the beautiful part for this academy. You are almost not doctors. So then why do you really need about the health conditions? What are you going to do? You didn't study as much as I did. I did study much more than many of you. And despite this, that health part is mine. But you have all the rest. Together, the people that work on disability have their own role. Doctors and those working in the health sector, they might deal with the health condition. And as I mentioned, the biomedical model for many of the health conditions doesn't work. But there's all the other part, the environment, in which everybody can have a role. The environment which constitutes the essential element to define disability. Environment that can be physical environment, social environment, attitudinal environment, political environment. What we would call the biopsychosocial determinant of health. You might not do anything on health because you didn't even study as much as you should have to become a doctor. However, you certainly can do much more than a doctor, acting on the biopsychosocial determinants to decrease disability. That is also was rising up the pressing needs for a classification that is called ICF, the International Classification of Functioning, Disability and Health. It is just a book, 1,400 codes. However, it brings inside what it is essential to describe functioning, which is this correlation and interaction of health condition and environment. If you imagine a McDonald's hamburger, you can see that the meat, which is inside, the body function and structures, the activity and participation, will never stay on if you only consider the health condition, which usually many countries in their own pension system, it is the only hooking element that you have to define disability, the diagnosis. But it is never enough. You need the other part of the hamburger. You need the environmental factor and the personal factor that are not classified in ICF. It was approved in 2001, and that was, and so far is still, the only cultural element that is been translated in 65 languages. It has been recognized as a theoretical instrument for discussing and maybe trying to see whether the UN Convention is finding something that is applicable or applied. Together with the ICD, the International Classification of Disease, which is only classifying diagnosis, it is part of the family of classification of ICF, of the WHO, and together with the ICI, the International Classification of Health Intervention, they constitute the three classifications that try to give some borders. In the ICF, that is the classification that I'm interested in describing to you, disability is defined as a continuum. Who is disabled? Where does disability start? Where does normality ends if disability is the opposite of normality? Where's the line between these two? So the distribution of world population on the disability continuum will tell you that we only have a minority on the severe part of the curve, that is the severe disability. The rest of the world is on the other part of the curve that is very big, and it depends where you put the political threshold to define it, that you will define how many disabled you have in the country. So the whole debate about the definition of disability is not there, and we do not know how many disabled that we have. Of course you don't know, because, for example, 18 years ago, the UN made a survey asking to countries how many disabled that you have, and it happens that Norway was declaring that they have 35% of people with disability, and Syria was declaring that they have 0. Of course, if you're not counted, you don't count. But then Syria had the war and everything, and I challenge now Syria to report that they have 0 disabled people in their countries. And also, it depends what do you define and where do you define your threshold to define disability, because it is sometimes attached to money, so then you don't count people because you're afraid that you have to give them some reimbursement. So then you ignore them, and if they do not exist, you do not have to pay for them. Very easy and simple. But if it is disability, then is the outcome of the interaction between health condition and environmental factors. What means to this academy is the environmental factors, because that is where you can act at policy level to make changes in the disability level of global population. And that is challenging, but fantastic, because it gives you areas that you can work on to change. While you might not be changed the diagnosis of Down syndrome, but you can always change the context where a person with Down syndrome lives. And that is the strongest political hook I can describe to you and I can share with you. The need for ICF, of course, it's important. Why? Because when I tell you about rheumatoid arthritis, what do you see? You see the body structure, the joints of this lady that are deformated by the rheumatoid arthritis. That is the diagnosis that usually will allow her to have some benefits. And then what will you see? Well, you will describe the functioning, say, well, the structure, they're altered, and she cannot really do the activity of daily living, like closing the coat and closing the buttons. But we always forget in this picture that she is a grandmother, and she, despite, and I go back to the despite again, but with a different meaning, despite her disability, she still wants to keep her role as grandmother. And she still wants to use her deformed hands to help her daughter and to help her grandchild. And so I think that the need for ICF is to change the perspective and to go into a different definition of disability intended as an umbrella term for, of course, limitation of activity, restriction of participation, and impairments in body function and structures. However, what counts is participation, which should be the outcome of any interaction, despite the physical or mental disability that you can have. So the functioning disability are multidimensional, yes. They encompass the human experience at the different levels, body function and structures, activity and participation, but always in the interaction with the environment. And I think that the role of this grandmother is what counts for her. What is counting for you? What is important for you? I think The biopsychosocial model allows a description of the global picture, an holistic approach to the person, not puzzles, not the eyes, that is the one for which you will get reimbursement, not the ear, not the mouth. You get reimbursement for a part of you, but you are you, and you are in where you live, what are your desires, what are your needs. So then there are no special needs. I don't believe in special needs. I think the needs are the same for everybody. But the accommodation to answer to these needs is different. Everybody wants to be loved, and everybody wants to eat, everybody wants to go out, everybody wants to have significant relationship, but everybody can get these things that are the usual needs with special answers. So for me, there are no special needs. There are only special answers to common needs. And I think that I go then into the third point, that is collaboration. I have only 4, so I'm always at the end. And the collaboration goes in reading everything that the world is trying to do nowadays. We are in a political era, and I think I can say BC and AC, that in the Catholic Church means something, but for me as a doctor, I would say before COVID and after COVID. And I'm saying this because the COVID has signed a difference in societal attitudes in many, many areas. But it is not changing what is going on at the international global level. We have the SDG, the Sustainable Development Goals. I work on SDG number 3 mostly because it's where I'm trying to move things ahead. And we have only now 7 years to go. And there are many things in there. There is a non-communicable global strategy that is working at UN, and there's the baseline report on decade of healthy aging. We have the action plan. As a neurologist, we have the WHO Global Action Plan on epilepsy and other neurological disorders, but also we have the mandate on rehabilitation 2030, that is provide disability, all people with disability, the proper rehabilitation worldwide. And 2 days ago, we had Dignitas Infinita. Everyone has their inalienable dignity. How I pronounce it? So then, I think that we are lucky. I mean, 2 days ago, this came out, that is paving our way, is giving the theory the church wants that. How do you, member, as academicians, with the responsibility and the role of making this operationalized worldwide? How do we work as academicians? I'm a member of the Pontifical Academy for Life. We have a lesser. I will complain with my president. I like your most, I would say. I like this. But that's beyond my conference. I'm saying that how can we, as academicians, have a role in making that theory and that frame of the Dignitas Infinita true? People don't have the right to have dignity. People need to become dignified persons. And the difference of having the frame and making this frame operationalized, this is what the Academy of Social Science has to do. How do you transform the frame of Dignitas Infinita into the reality in country level of what is the dignity? And I think that ICF classification as such is an instrument which has done and has put a hierarchical list of categories. And why do we need it? Because we need a common language. When I say disability, I cannot hear anymore the word handicap, not because of cosmetic reasons, but also in my country. We have the law for handicap because we are unable to change it. But I think that we are trying, and it's not only cosmetic, because it's not person with disability what counts with disability, is person, the point that we are trying to put in common. We are all persons, so that is the commonality. How can we change this? It's a work. It's a conceptual model, the ICF. He is telling that function is not only about what a person cannot do. You mentioned, Baroness, is what person can do. But who cares what person can do if the person can do this in the loneliness of his room? If nobody's looking what you can do, I don't care what you can do. I keep you close in a room. And I think that then it is important to define a profile of disability and function, not only because we are treating the problem, but because we are addressing people's needs in relation to their lived experience in their own context. So is the best indicator of treatment needs and service outcomes. You will hear later from my colleague and friend, Professor Jérôme, speaking about human functioning revolution. He has been writing about it. And it is about speaking about functioning despite the impairment. So the WHO concept of human functioning, it is a way to rethink health. It's a new understanding of health with a wide range of consequences. Functioning is not just the outcome of health, it's capturing the lived experience of health, which is intrinsically in health, but is not so well clarified. It's like denying responsibility of society, while the lived experience of health is accounting for the value of health, both for the individual and society as large. So in a sense, the concept of functioning is integrated in biological health, which is where I work as a doctor, but the lived health, the person's actual performance in interaction with the environment. So it is key to value health in relation to the individual and to the environment. We will never reach the SDG number 3 if we do not work thinking that what we are doing in terms of political engagement is to work for the il bene comune, the common good, which is the public good. What is the common good? I think we have Nobel Prizes here. You can say that economically is something that is very clear to you. I challenge you, economists. You are guiding us, but I think that you should look at us a bit more, because people with disability face barriers in all areas of life: education, employment, social and political life, community participation, and health, which is bringing us that these barriers are bringing, and they are evident, and they have nothing to do with the disease itself. Inadequate policies and standards, negative attitudes, lack of provision of services, problem with service delivery, inadequate funding, lack of accessibility, lack of consultation and involvement, lack of data and evidence. Where is my role as doctor here? Is not here. Where is the role of health here? Is not here. Is the whole role of all the political people, whatever is their role, to change these disabling barriers and make them facilitate. Because barriers have negative consequences. There is lower educational achievement, lower level of employment, higher rate of poverty, poorer health outcomes. I was member of the Italian government group writing the UN Convention. And there is a point in the UN Convention in which you will read at page 3 that when we speak about people with disability, we also include women and children. I remember that debate. Women and children were not considered persons. And there has been a point in which the debate was February 2005. And there was this big call in which there was an opposition to include women and children in the concept of person. Because if you are a person, in many countries you have rights. If you are ignored as a person, you do not have rights. So if you are a girl with disability in a country in which you're not counted, and you're not a person, then there's no problem if you do not have any health insurance or you don't go to school because you're not a person. So you will find in the convention at page 3, that when we say person, we include also women and children. We did have to specify. It was led by Sweden, by the way, that debate, and all the Northern European countries went on, and they were saying we are not going to sign the convention if you do not put that person are also women and children. And I would say that this brings us to the culture of discharge, carto in Italian. I like the Italian word more than English. Discharge doesn't fit to me, but it is what the Pope always says, the contemporary impatient, because we are impatient. We only want men, 40-year-old, beautiful, healthy, working, productive. Well, they rest in that manner, 30 seconds, they also age immediately after. So I would say that contemporary today is the culture of discharge, of those that are not perfect, healthy, productive. And it reminds us many, many things. But then we go to my last point, which is commitment. And commitment follows all the others, because it is what are we engaged in. Well, and then I want to speak about what I'm working on. I was consultant of the Ukrainian government in 2021. And I was dealing with the reform of disability assessment because they introduced ICF in Ukraine to change the perspective. And I was consulting in Turkmenistan, Kyrgyzstan, Kazakhstan, and Russian to make a change of the old system to consider disabled people in those countries. So I was aware of how it works, the disability system in those countries. And I was monitoring with ICF the application of the UN Convention, because all these countries ratified the UN Convention. So I underline that I think it was an issue of friendship. I underlined it was important to start resistance from what we do. We are men and women of science, culture, and of art. And I think that whatever bridge will have to be built will pass through that. And as a woman of science, I think that bridges, whenever will be the time, we'll have to start somewhere. And we are lucky because we belong to those cultures, these 5% of the world. We're so lucky and spoiled that we can be those that keep the possibility of these bridges open. But my famous #1 rule is look for the crazy ones who fuel human resistance. There are crazy people who do everything to destroy the world, but there are also crazy people that do everything to save it. And I am so lucky. I know many of these second crazy people. I find easier to align myself with the latter. Even everything around seems hopeless, and despair must always be fought everyone as best as you can. I personally have been fighting it for 30 years of work, staying close to family and friends. And therefore, as I'm staying close to Igor Boyko and Sister Justina. They're my friends. Sister Justina Holuber, she's a geneticist, a psychologist. She founded the first hospice for neonatal and newborns in Ukraine, and she does palliative neonatal care, and she is the first neonatologist doing this. And Father Igor, she is the son of the Church of Silence and of those persecuted under the Soviet Union. And he was tasked by John Paul II to found the seminar, of which he is now rector in Lviv, in Ukraine. They are both members of the Pontifical Academy for Life, and they are my friends. That's where we met. When the war started, I decided you don't leave the friends alone, and I started to go to Ukraine. And I started to look and to work with them because I was already working with the government, and so I was interested in what's happening to disabled people during the war. And of course, on Lancet, there was this immediate paper that says that there are public health consequences of war, and it came out 3 weeks after the beginning of the war on Lancet. But also, I was following the appeal from Ukrainian disabled people, like in all wars, people with disability are those that suffer most. I am a member of the task force about war in Ukraine of the WHO, and we've been working on the situation of refugees with disability outside. But I had a question. I was aware before the war we had all these internats, these institutions with more than 260,000 people in there. And I was seeing at the beginning of the war that all these people with disability were going out. People with deafness were going to the Netherlands, to Italy, mostly blind people were going to Spain. I was wondering, were they liberated from the institutions that I was trying to close together with UNICEF and the European Disability Forum, or it was emptying this institution for Ukraine? So I did these questions also to Ukrainian colleagues because it was an issue. Will they ever be back to go to Donbass? And then, of course, the issue of the 15,000 kidnapped from the east part of Ukraine came out, and now is Cardinal Zuppi following them, out of which 4,000 are kids, and I'm also following that. But the internet, what is this? The so-called Soviet Model Institute that I've been seeing in all the countries where I've been in the post-Soviet Union, and it is called transit orphanage, meaning that, as you said, in fact, not all the orphans in these places are orphan, but what it was said by the system is that you are not able to take care of your disabled child, you are poor, it's better if you put them in an institution. So majority of the kids with disability or with something, either they come from very fragile family, prostitutions or alcohol abuse or other things, or they're real orphans. Before the war, we had 260,000 in the internats, and now we've lost control of what's happening in the east part of the country because many have been closed and many of these orphans have moved to the west part of the country. And situation in many of these is very bad. But I'm following with the European Disability Forum the experience in Bulgaria. In Bulgaria, they've been taking all the families who've been putting their children here, and with an education program, they've been able to bring back from orphanage to families, original families, 48% of the kids who were in some internats. So now we are following some experiments in Ukraine to educate the family, to bring children back to their families just by educating the family and supporting the family. Of course, this opens many things. But there's also another group of disabled that came out, which was not there before, which is the veterans. Of course, they do not consider themselves disabled. They call themselves heroes. And they do not consider to be the same as the disabled of the internet. However, from the international perspective that I have, they belong, for the concept of biopsychosocial model, to an area that needs facilitation. Just as a matter of fact, 2 days ago, the Times published that also in Russia, we have more than 500,000 new disabled that are the veterans of war. So we don't speak about this, that is going to be the heritage of war for ages, right? But so then I decided, okay, let's work with the crazy ones. And that's what I'm doing with the Catholic University of Ukraine and Italy, a course on disability management in Ukraine, in Lviv. And what we do in this, I want to train the first generation of disability managers in Ukraine, and we have been developing 4 case studies. We are going to create the first generation of disability manager in Ukraine, and we started the course last month. I'm sharing it for you, and I'm closing my conference now. I'm sorry for taking your time, but we really think that using the convention and using the ICF, it is the way in which we can speak at disability, also in a place where you had the internet, also where disability was to be hidden, also where disabled people were hidden from population. So the worst ever thing that can happen to a country, which is a war, could be the opportunity to do something different, good. Taking out children from the orphanage, speaking about disability in a different manner, changing the culture of inclusion, moving towards a complete non-accessible country, towards a country that is different from as it was before. So the conference started. She's Tatiana Lomakina. She's the counselor of Zelensky for disability and accessibility issues, and his father Igor, and she is the coordinator of the course, Yarina. The disability manager is responsible for the entire process of inclusion and integration and main issues related to the new scenarios that Ukraine has. You never had disabled people walking in Lviv until the beginning of the war because they were hidden in orphanage. And last year, when the first disabled person was walking in Lviv, we realized that nothing was accessible. No shops had an entrance. There was nothing in terms of transportation that could allow them to move. All the streets of the villages of Ukraine, they are completely inaccessible. And so we decided, okay, we need to do something. We start from a class, culture. I think culture is what I'm able to do. I'm not a politician like many of you, but I can teach. So let's start with what you can do. And that's the first class of disability managers in Ukraine last week. And we have 4 cases, and they will work with this. We'll present it to the government. Case 1 is disability management of children with disability, pathways towards participation and inclusion. It's already challenging this. The second group is working on employment and disability, the Pizzeria Vittoria, because I'm opening a pizzeria in Lviv, an inclusive pizzeria. So we work on the case model of opening inclusive pizzeria in the country. And to speak about inclusive employment, why do you need people to work with the others? And disability management in the transition from internat to home, we have chosen one internat, and we tried the pathway to close it towards bringing the children back home or making a family home in which we will take the children that have no family anymore. And we work with the Superhuman and Unbroken, which are the largest rehabilitation center for veterans, to see what happens after you finish rehabilitation. How do you send back these men and boys? They are 25 to 35, more or less. They are married, they have kids. The age of their kids is usually 2-3 years, so they're all young people. What does it mean, inclusion, participation, going back to work? So we use ICF. And its definition, any person in any moment of life can have a health condition that in a negative environment becomes disability. So the crazy people who work on human resistance turn tragedy into an opportunity, fragility into a cure, desperation into hope. These crazy people meet in the name of friendship, culture, knowledge, esteem, love, and for those who believe, faith. And I think, really, to say that when everything is dark, even one candle makes light. So any of you can be a candle. And I think this is the message that the church should give. We can all be candles, and so many people can be candles to us. It was said already, globalization made us global, but didn't make us brothers. I think in making us brothers, that's the hope, that everybody's a candle for the others. And that's, I think, the message that should come out from this Pontifical Academy, because be crazy is the time for the human functioning revolution. Thank you very much.